This is Nursing Australia, proudly brought to you by APNA, the Australian Primary Healthcare Nurses Association.
Hello and welcome to Nursing Australia. I'm Suzanne Blackeby. Here in Australia, the rollout of COVID vaccine has begun. Not without a hitch, but we're on our way. In this episode of Nursing Australia, we hear how APNA paved the way for nurses in general practice to work to their full scope of practice, with Medicare billing number descriptors allowing for flexible nurse-led clinics for the COVID vaccine rollout.
I'm shocked that nurses have had so little input into the actual rollout, but I think our influence has seen everyone come to their senses.
We're joined by Professor Julie Leese to talk about vaccine hesitancy and what to do.
In Australia recently, we've seen a bit of a decline in the proportion of people saying, yes, I'll have the COVID vaccine, and a little bit of a rise in the proportion saying not sure or no.
We discuss cancer and the important role primary healthcare nurses play in a patient's care.
So I think we need greater awareness that primary care and shared care is the way to go. And we need people working together to create some sort of national agenda or national standard.
And then Dr Avi is back to discuss how to engage and motivate. But first, the news.
The rollout begins, a nurse steps in during a COVID vaccine overdosing error, the WHO warns of long COVID, and the Royal Commission into Aged Care final report handed down.
This is Nursing Australia News.
Hi, I'm Mitch Wall. Australians in high-risk priority groups have started to receive the Pfizer COVID-19 vaccine. The groups eligible in the initial stage of the rollout including frontline health workers, aged care residents and staff, and quarantine and border workers. At last count, nearly 7,000 first doses have been administered so far. 3 days into the rollout, a doctor in Brisbane that had not done the required COVID-19 vaccine training gave 2 aged care residents up to 4 times the recommended first dose. Federal Health Minister Greg Hunt says it's a concerning incident.
The doctor involved did the wrong thing, and that is a case of human error, a case of unacceptable human error. And so as a consequence of that, the doctor was stood down.
A nurse stepped in to intervene in the situation. Queensland Premier Anastasia Palaszczuk applauded her efforts.
I'm advised that was only the intervention of a nurse that prevented further overdoses. I applaud that nurse for her actions.
The federal government have removed some barriers that would have constrained practice nurses during the COVID vaccine rollout. The new MBS items will give greater flexibility for general practices and similar services to facilitate improved access to the vaccine for our community. The World Health Organization has urged healthcare professionals to be on the lookout for so-called long COVID symptoms. The WHO say 10% of COVID patients are still unwell many months after their initial illness, and for some the effects may last for years. Professor Martin McKee, who led the WHO study, said the symptoms are varied and can be debilitating.
Chest pain, muscle pain, fatigue, shortness of breath, and what patients describe as brain fog.
With nearly 30,000 Australians now being diagnosed with COVID-19, this means there may be up to 3,000 people in the community suffering from the trailing effects of the virus. And the long-awaited final report from the Royal Commission into Aged Care was handed to the Governor-General on Friday the 26th of February. More detail on the contents of the report are expected soon. It's expected it'll recommend sweeping changes across the aged care industry.
The Australian COVID-19 vaccination program is up and running, with thousands of Australians expected to be vaccinated in the coming weeks, including residents in aged care. While this implementation has been rushed, it's great to have it underway, and we wish all aged care nurses well as they take the lead. A major concern for general practice nurses has been the Medicare Benefits Scheme items for the rollout. APNA understands that not providing a way for nurses to bill for their time to give the COVID vaccines would restrict Australia's 14,500 practice nurses from playing the fullest role they can in the rollout. In the last few days, and after significant engagement with government, APNA welcomes the removal of some of the barriers that would have constrained practice nurses. To discuss the changes and the role APNA has played, I'm joined by APNA President Karen Booth. Thanks for your time, Karen. Can you start by telling us how the Medicare billing structure recently announced will work in general practices rolling out Phase 1B across the country?
I think this is going to be a pretty exciting time. And whilst APNA doesn't agree with the particular type of funding model that the government has chosen. We'd have much rather seen bulk payments going to practices. I think this is a short-term reasonable compromise, and that nurses will be able to, once they've done the training for the COVID-19 vaccination modules, will be able to do the suitability assessments and then to actually give the vaccine without the patient necessarily seeing the doctor. Now, on a day-to-day basis, you would expect this for authorised immunisers to be able to do this anyway, but that has been extended to registered nurses who are working inside the practice with the GP on site. And if a GP assesses a patient, then enrolled nurses are also authorised, if they have done the COVID-19 training, to do the COVID-19 vaccines, of course, under the supervision, direct or indirect, of a registered nurse. So that is basically where it sits. Unfortunately, nurse practitioners don't have an item number for this, but we have been lobbying for that, as has ACMP, for some time.
Karen, can you tell us how APNA's been able to influence this decision?
I think the best way I can say is we have been actually lobbying very hard. APNA has been involved with vaccination programs from the day dot, and in fact we're very heavily involved in the swine flu vaccination program 2009-2010. So we have nurses out there who are used to handling multi-dose files. But for this particular campaign, of course, we all need education. The influence has definitely been direct lobbying. I'm shocked that nurses have had so little input into the actual rollout, but I think our influence has seen everyone come to their senses and taken on board the comments that APNA has made, the comments that other nursing groups have made. And now we can see a reasonable compromise in these item numbers that we will see and a descriptor that will allow general practices and like organisations to utilise the skills of their nurses in a flexible way to run nurse clinics for the vaccine program. If you have a big program, it's a public health program, it's not just a general practice program. You need to have manpower and you need to have fast throughput. And these item numbers will help that. It's not the perfect model, fee for service, but at least it's a start.
Karen, do you think that this is the model that will be in place for the entire rollout, or do you think there is potential for government to reassess and look at bundled payments to allow nurses to continue to expand their role in the rollout as we move through the different phases?
If you've got any big program rolling out, you actually need to look at numbers, you look at throughput, and you look at success of the program, and you have a risk management strategy in place early. Part of that risk management would be a review of the program to check its progress along the way and particular intervals. So in 3 months' time, if we're not looking like we're getting the targets that we need for the general population with the expected rollout to be finished by October, then they need to review it. Then they need to look at how better can we run this program. Do we expand the capability of general practice with things like bundled payments so that nurses can just get on with it? The problem with fee for service is that doctors take home, as part of their usual commission, between 60 and 80% of payments. If it's a long-term program, that may affect the financial viability of practices running the programs, and then we might see other initiatives like public health opening up clinics in town halls just to get people through. But I think it's a start. The next will be a review and then maybe hopefully move to a more bundled payment model.
Thanks for your time, Karen. In the show notes, you can find the link to the MBS fact sheet where you'll find more information. And watch the APNA COVID page for up-to-date information affecting the COVID vaccine rollout.
Did you know that on average, APNA members claimed over $3,200 through APNA's professional indemnity insurance in 2020? Join as an APNA member in March and add on insurance for only $130. You'll receive 13 months for the price of 12 on membership and insurance. Click the link in the show notes of this episode or visit apna.asn.au/insurance.
To ensure nurses are up to date with the latest on the COVID vaccine rollout, APNA are hosting a special series of live webinars. The recordings of these are available here on Nursing Australia. To view the slides for the webinars, listen to Nursing Australia via the APNA website, or if you are listening to audio only via a podcast listening app, there's a link in the show notes to the slides for each episode. In the third webinar, Julie Leask took us through vaccine hesitancy and what to do. Julie is a professor and social scientist at the University of Sydney. She studies what people think and do about it, programs and policies. She has a background in public health and prior to that in nursing and midwifery. She's a visiting fellow at the National Centre for Immunisation Research and Surveillance, NCIS, and advisor to the World Health Organization.
This is a great opportunity to share with you what we've learned in our research in addressing vaccine hesitancy. Yeah, I'm going to talk about these things. The vaccines. I'm going to share a little bit about the vaccines themselves. I know you've probably heard quite a lot of information, but I think it's helpful just to get some of the basics, particularly from the clinical trials. Look at hesitancy itself and communication strategies around that, including dealing with misinformation, and then look at how you manage hesitancy and refusal in the clinic, and focus at the end on the value of vaccines, which are part of a good conversation about vaccination with any individual as well. And then focus on, at the end, after we've gone through some communication tips, some of the other strategies that will improve uptake, because it's not communication alone that will do that, as you know. So we're going to start with a role play, and Suzanne and I are going to launch straight into a conversation with a hesitant person. And the setup is that this is a fictitious conversation that's kind of slightly based on a real conversation. And this is a conversation between, it's actually Amana and a practice nurse. And Amana is having her leg ulcer dressing removed, and she's 85 years old, and you are her practice nurse, and you're in a large, busy clinic. Now, I'm going to play the role of the nurse, and Amana is going to be played by Suzanne, and you'll note that we are Academy Award-winning actors here. But here we go. So I, as the nurse, I'm actually taking that bandage off right now, and Amana comes in with the conversation.
What about this COVID vaccine? I don't know if I should get it.
Why?
All those people in Norway died after the vaccine, and I don't know, it just seems so rushed.
Oh, yeah, the Norway thing, that they were old and terminally ill.
Yeah, but we can't be sure. And anyway, they rushed the vaccines.
Sure, but the TGA has been through all the safety data and they've verified that it's safe. It's safe and effective. It's fine.
I don't know. I'm not anti-vaccine. I just...
Look, there's a lot of news out there and there's a lot of misinformation that people are picking up at the moment. And particularly on Facebook now that we don't have the news on.
I'm not on Facebook. My sister had a flu vaccine and she got the worst reaction.
Oh, well, yeah, sure. But lots of people think that after a flu vaccine, the flu vaccine doesn't give you flu. So it probably wasn't, if it was, it would have been just a minor reaction.
Well, you can't be sure. With the new things they put in the vaccines, what they do to your body.
Yes, but the safety studies have actually been very robust. I think you've just got to ask yourself as well, if you got COVID, how would you feel? And if you got it and passed it on to your sister, how would you feel? Because you basically put yourself and others at risk if you don't vaccinate.
Oh, look, are the doctors ready?
Oh, okay. All right, so that's the end of that role play. And what I want you to do now is to just put in the chat function some of your observations about that role play. Okay. So as I talk, I'm going to just read a few of these. So the patient was hesitant to listen to the information. There was a dismissal of the patient's concerns. The nurse didn't validate the patient's concerns. Great, keep it coming. Excellent. Dismissive. It didn't provide the specific information. Not sure why whys were given and opportunity to be expressed. The nurse came in too fast, absolutely. Dismissive, not really engaging, etc. Could be more understanding, and education is the key. Okay. Don't use abbreviations like TGA, good spot. I think the arguments are valid by the nurse, but I think the approach was teacher-like. Yeah. It's probably how I look when I'm lecturing my children. The nurse didn't give the patient any confidence in the vaccine. Great, fantastic, thank you. So that is an example of a scenario that didn't go so well. And what I want to do now is focus on the things that Amana was concerned about, was hesitant about, at least some of them. And if there are other questions you have, put them in the Q&A. But I want to first start with the vaccines themselves, because there is this perception out there, it's quite common, it's held by about a quarter of people, that the vaccines were too rushed and therefore they're not safe. And what usually happens is that you have a traditional vaccination development and approval timeline, which goes over many years. The phases are sequential, and the regulatory approvals can be slow, and it can take time to recruit thousands of people for the trials. With the pandemic vaccines, a lot of these phases are done at least in part in parallel with each other. And that means that phase three is this long in a traditional vaccine timeline, and it's the same length of time in a pandemic vaccine timeline. And phase 3 is when they look at safety in all phases, but phase 3 is when they're looking at people who get the vaccine and people who get the placebo in thousands, tens of thousands of people, to look at whether there are differences in serious side effects between the two groups. They've also had many trial volunteers because people wanted to help get these vaccines tested. And they also ramped up production capacity before they finished phase 3 trials at some risk. But that meant that they didn't have to wait to get that all ready once the phase 3 trials were finished. So, and they did that with the most promising candidates. So that's why we've got this, in a way, miracle and good thing that we've got these vaccines as quickly as possible. Okay, so what about the vaccines themselves? This is an article which shows some of the vaccine platforms on which they're being made. And in Australia, we have right now, of course, the Pfizer BioNTech vaccine, which is an mRNA vaccine. We have 10 million doses on order now, and we have a further 10 million possibly in this latter half of the year. You have to store them, as you know, at -70, and they can be outside that ultra cold storage at 2 to 8 degrees in a vaccine fridge for up to 5 days. 2 doses are given 21 days apart. The viral vector vaccines, so AstraZeneca, are based on the adenovirus And they use that technology, that platform, to teach the immune system to recognise COVID. And these vaccines are much more convenient and much more deliverable to diverse settings because of the normal vaccine fridge temperature range that they require. We are able to make the supply in the country as well, which is a good thing. And 2 doses, well, they haven't put out an actual recommendation yet, but the trials say that the greatest efficacy is with more than 12 weeks between doses. And we will later hopefully get the Novavax vaccine, which is a recombinant protein vaccine, 51 million doses for that. So these are those platforms, and here are the vaccines that are already using those platforms. So the viral vector platform is the platform that the AstraZeneca vaccine uses, and that's already been used with the Ebola vaccine. So that's a new technology, but it's got a precedent. The mRNA vaccines, DNA vaccines, are a new technology with vaccines, although there's been 2 decades of research on this technology. But these are the first mRNA vaccines we have. So yes, they're new. And that's why they needed to evaluate the safety carefully in the trials. And here's a summary of the 2 phase 2 and 3 trials for the AstraZeneca vaccine on the left and the Pfizer vaccine on the right. I'm going to focus on the Pfizer vaccine. Nearly 44,000 participants. They ended up getting 170 cases of COVID in the time frame that they've reported on. The placebo, so one group's randomised to get the vaccine, one group the placebo, which is normal saline. Often they'll give a vaccine as the placebo. The good thing about normal saline is you can look at systemic side effects in the vaccine and compare them with the people who are getting a saline placebo. And that's quite interesting, as I'll show you in the next slide. The safety evaluation period was 2 months after the second dose. They prosecuted serious adverse events and found pretty well the same rate in both the vaccine and control groups, the placebo, the saline placebo groups. A lot of people got injection site pain, other local side effects, fatigue, 51%, headache, 39%, and anaphylaxis post-marketing surveillance indicates in a recent study that it's happening at 5 per million doses in the US. And that most of those, 74% of those occur within 15 minutes and a further within half an hour of the vaccine being given. And most of those people had a history of it. There's detail on the left about AstraZeneca, but I want to move on to the hesitancy side of things. But before I do, just show you this really interesting graph from the phase 3 trial report. So this is basically showing people with local and systemic reactions within 7 days after injection of the Pfizer vaccine in the over 55-year-olds. So the under 55-year-olds had a higher rate of local and systemic side effects. I'm showing you the over 55s because we're more likely to be vaccinating over 55s in the initial groups, and of course the occupationally at-risk groups who are probably more likely to be younger. But you look at things like the most common systemic side effect, which was fatigue, and there was a small proportion in orange who had severe fatigue, and the placebo group, so the blue is moderate fatigue, the green is mild fatigue, and the placebo group also got tired, right? So that doesn't mean that it's not real. It just means that there is a psychological aspect to receiving a vaccine. But it was more common in the vaccinated group. So your patients can expect to feel tiredness, some to feel headache, some to feel chills and muscle pain, and many to feel pain at the injection site. And it's important they're ready for that. Because if they're not and they get a shock, it can put them off, as you know with patients who might have had a reaction to the influenza vaccine. So what about hesitancy? Well, right now we are in a formative time because vaccine attitudes are usually stable, but with the COVID vaccine, like any new vaccine, it tends to be trusted less, particularly with the rapid development timeframe. And we're in this volatile environment. There's greater belief in misinformation and conspiracy theories. People's lives have been upended and destabilised, and there's great change, which makes it harder for people to establish trust in new things. The stories in the media have a greater capacity to change acceptance. And in Australia recently, we've seen a bit of a decline in the proportion of people saying, yes, I'll have the COVID vaccine, and a little bit of a rise in the proportion saying not sure or no. If we look at the who is less willing to vaccinate, yes, it's females, but it's not a massive difference. So it's something like for males in a recent survey from ANU, it was 84, and for females it was 79. So these are not massive differences. These are just relative differences that are being picked up. Those in this 25 to 34-year-old age group, but interestingly, younger and older people are more willing to vaccinate. Those speaking a language other than English at home, those with less than year 12 education, those in outside capital cities, and those experiencing financial distress. So it's possible that those who have had a more difficult time, been more affected with COVID, are more likely to be feeling hesitant and unsure about government processes in general, because trust is important. Those who are hesitant are more likely to be concerned about the vaccine's safety, as you can imagine, its effectiveness. They're more likely to feel uncertainty. They don't perceive COVID to be as risky. They're more likely to think people have made a big thing of it, and to have less trust, to believe conspiracy theories, some of them, not everyone, but some. And then on the positive side, those who are more willing to have the vaccine, are more likely to be confident in it, to perceive the risks to be high for COVID, and to trust their provider and believe that their provider would recommend it, because your recommendations are influential, whether it be with your patients or your communities or your family and friends. You are influential. This is interesting data from YouGov, which shows all the countries where people have said, no, I won't take the vaccine, and what proportion of that group say they're opposed to vaccines in general. So for Australia, we have 15% in this particular survey saying, I won't have the vaccine, and 2% saying, and I'm opposed to vaccines in general. And those people who are opposed to vaccines in general tend to be labelled anti-vax. That's not a helpful label. It's better to just describe them as people who are opposed to vaccines in general. But the point here is that if you don't want to have a vaccine, it doesn't necessarily mean that you're against a vaccination in general, the COVID vaccine. So there's quite a bit of hesitancy out there at the moment. This is a helpful way of thinking about the different people that you're speaking with. So you go from people who are anti-vaccination activists, a small and vocal group. Then you've got people who are planning to reject the vaccine, like that bigger group, that, 15% minus 2 in that survey. So 13% in that survey who are planning to reject the vaccine. And then there's a group who are just very hesitant. There's a group who are planning to accept the vaccine, a group who want the vaccine now, and they want the best vaccine they can possibly get, the one that has the highest numbers of whatever. And the people who are advocating for vaccination. And what do we do about these groups? So from a communication perspective, it's sort of more of a big picture, public communication level. The tasks might look like this. And think about this when you're maybe having conversations on Facebook or in social media or in your environment with others about the vaccines. With the activists, you don't want to give them oxygen. You want to minimise their impact. With those who are rejecting vaccination at this stage, you want to keep that bridge there. So if they start to rethink it, it's still there. So with Amana, she's not going to want to talk to the nurse about vaccination again in that scenario. For the hesitant, you want to address their concerns and questions well, and that means keeping up to date with the information on COVID-19 vaccine. If you're an immuniser in this program, it's going to be your job to keep up with that information and read it. For the accepting, you want to make sure that they have a good consent process and a good clinic experience, because they'll take that back to others. With those who are demanding vaccination, it's about managing those expectations. And for those who are advocates, we want to give them the tools to support their advocacy in diverse communities. So what about responding to misinformation, which is such a concern and a challenge in this day and age? Well, it's important to ask a few questions like, is this being shared a lot? Is it likely to affect those people around me? Are there silent audiences who are wondering and now concerned about the vaccine, whether it causes ITP, for example? Is it affecting people's behaviour, stopping them actually wanting to vaccinate? Then prepare people. Let them know. You might hear people say X, Y, Z about the vaccine, and the facts are this. And when you give people the facts, here's some tips from communication science, in this case, a vaccine and misinformation guide from UNICEF and colleagues, which talks about how to respond to misinformation. You start with the fact you want people to remember, not the misinformation. So if it's vaccines have microchips in them, you want to start with the fact, which is that vaccines are not made with microchips, or whatever the core fact is. Then you want to warn people, let them know that they're about to hear the misinformation, so you kind of mentally inoculate them. And then you give the fallacy, and then you end with the fact, right? So you give a kind of information sandwich. And you want to respond early, because other people will fill the gap if you don't, if there's a desire for information from people. Use trusted spokespeople, and you're trusted in your clinic settings, in your family and friends, in your social networks. People will ask you what you're doing about vaccination. And don't feed the trolls. The trolls being the people who are energized by ribbing people about vaccination, provoking them, who just want to have a debate and air their views. And remember that, as I said before, how people experience a clinical encounter is influential, and it might influence other people. And this is a wonderful perspective gathered by Amy Crichton, who was interviewing people in her Gomeroi community around maternal vaccination. And one of the participants said to her, so the service may have spoke to one mum, but guess who that mum has spoken to in the next couple of hours in this Aboriginal community? 20 mums, and she's passing that on. You might not have that flash brochure, but the power and the time that you've put into her, she's putting that into her friends. And every time I read that quote, I get a chill because it's such a powerful statement. So what does good vaccine communication look like? I'm sure some of you would have heard us talk about our research on vaccine, on helping clinicians, helping health professionals like you have constructive conversations about vaccination. And we have developed a system for those conversations in primary care between parents and health professionals called SKY. And the website is talkingaboutimmunisation.org.au. And there's also a provider website that you can access through NCIRS and do some training. And I know you're probably overtraining at the moment, but it's useful because it has relevant to any vaccination discussion. So what we say here is that you kind of take, instead of clinical pathways, we're thinking about communication pathways. And people, after you talk to them or you hear from them or you look at their vaccination history, will either be ready to vaccinate, they'll be hesitant, or they'll be planning to decline vaccination. And your approach to them will need to differ. Your goals with them will need to differ, and the time taken might differ as well. So with people who are ready to vaccinate, again, it's that good process that you want to be thinking about, managing consent well, helping people be ready for adverse events following immunisation and know what to do to report them. For the hesitant and the declining, here's what we recommend. That first of all, if someone signals that they're quite hesitant, like Amana did in the role play, you want to elicit questions and concerns. And in the process of doing that, you might hear someone say, well, the vaccine's got nanos in it, or deaths in Norway, or whatever, and want to jump in because you might have learned about that in an update. You want to jump in and correct that wrong thinking. But what we suggest here is just holding off briefly and thinking, well, I'm going to listen for a while. I'm going to ask a couple of questions, and I'm just going to think about what my goals are today. And don't necessarily be unrealistic about your goals. If someone's really resistant to vaccinating, this might be the start of a conversation with them and the start of a process. But if they're looking like they're really thinking about it, you might want to end in recommending vaccination. But how you get there is important, because you're in a better position to recommend vaccination if you've taken the time to build that rapport. So acknowledge concerns, validate, elicit questions and concerns until you hear no more, because sometimes those late breaker ones are the real issues. Share your knowledge, offer resources if you don't have the knowledge on hand, elicit their own motivation to vaccinate, and ask them maybe if they're concerned about COVID, what about travel, what are their plans there. Recommend vaccination, give quality information, and keep the conversation going. And that can be with people who are hesitant or declining. Here's the deeper stuff. So often the concern is around, the manifest issue. The one on the surface is the vaccine safe? Does it work? Is it needed? And underneath that is usually more fundamental values and moral intuitions and concerns about things like this. The desire for protection of one's body, perhaps against a vaccine. The desire to keep the body pure, this notion of disgust or trouble that there's something artificial going into the body that's got these mysterious things in it. The desire for self-determination in what one does with one's body around vaccination. Grief, if someone's experienced a negative event in the past or a healthcare related trauma, they may respond to vaccination in that way and channel their grief through the vaccination topic. And belonging, if you're in a network where it's more common to question or not vaccinate, then you're more likely to be that way as well, because contagion of ideas. So let's go back to the role play. And are you ready, Suzanne? We're going to go into that scenario with Amana, and we're going to start at the same place we did. Okay, go.
What about this COVID vaccine? I don't know if I should get it.
So you're unsure?
Yeah, all those people in Norway died after the vaccine.
Uh-huh.
And I don't know, it just seems so rushed. It's not like the COVID is around.
Yeah, so it sounds like you're a bit worried and you're not sure whether it's worth doing anyway.
Yeah, and my cousin said something about putting tracking in the vaccines. She's a bit conspiracy theorist type, but with the government, you never know.
Okay. Are there more concerns you have about it?
Yeah. My sister had a big reaction after the flu vaccine. It was awful. She was really sick.
Oh, I'm sorry to hear that. So, yeah, that sounds scary. So let me summarize. You've mentioned the rush on the vaccines, the risk of getting COVID, and that you don't see it as being that high. And your cousin's mention of the tracking stuff, but also your sister's reactions. Does that sort of summarize what your concerns are at the moment?
Yeah, definitely.
Sure. Look, I think it's normal to feel a bit unsure at this stage. These are new vaccines and they have been developed quickly. I was actually at a training session the other day run by the Australian Primary Care Nurses Association, who have excellent training sessions. And they gave us a bit of information about this. Can I share what I learned with you?
Yeah, please. Got to wait for the doctor anyway.
Yeah, and then we'll have a little chat about your sister's reaction as well. So they have been developed in record time, it's true. And what they've done is they've moved through that red tape very quickly. Everyone's been very determined to move things at a good pace. And normally a vaccine is tested one phase then the other, so it's sequential. But with the COVID vaccines, they're putting some of these phases at the same time so that they can move through the phases quickly enough to get these vaccines ready, because we're in this global emergency. But they have still tested for safety in the same way they would any vaccine. So there's been tens of thousands of people in the trials to look at whether they prevent COVID and to look at side effects. And they've now been given to over 200 million people around the world with no major safety issues that have been reported. So things are looking good so far, but of course they're going to keep monitoring that. I can also give you a bit of information about the side effects you might experience before we finish as well.
Oh, okay. What about long-term side effects though?
Yeah, so they'll follow the people in the trials for 2 years. But long-term side effects are quite rare. Usually if something's going to happen, it's going to happen within the first 2 months after a vaccine is given.
Wow. I don't know. I'm not anti-vaccine. All my children were vaccinated. They've had their polio. Well, I guess COVID's a bit like polio, so maybe I'm being too cautious.
Yeah, look, I know you have your flu vaccine every year. You're right. COVID is a serious disease and we haven't had much of it in Australia. But if you look at those intensive care, I just look at those wards on the TV, the intensive care, and I just think we're so fortunate we don't have that. But we need, COVID would affect us if it really got into Australia, as it did in Melbourne and in the Sydney outbreaks. Look, also, they think travel will eventually become easier as well, and that's a kind of a good thing for us too.
Oh, definitely. My sister lives in Perth, and last time I tried to go and visit her, my flight got cancelled and the borders closed. It was awful.
Yeah, exactly. So, look, Amina, we've been talking about this for a while. You're 85. I am concerned about you being at greater risk of COVID. I'd like to see you vaccinated. So how about I'll give you some information and you can go away and discuss it with your family and have a read and see how it goes.
Yeah, that'd be great. Thank you. I'll talk about it with Tony. He's always worried about my health.
Great. I see the doctor's ready. So let's talk about your sister's flu vaccination's reaction at the next visit as well.
Okay, thanks.
Okay, so that is the, thank you very much, Suzanne, for that, yet again, Academy Award winning performance. I think we're both going to get statuettes at the end of this. But I guess here are the things that you might have been looking out for and noting as we went along. And let me just see if there are any particular comments in the chat. Yes, thank you. More supportive listening, empathy, sister, listen to ask questions, allowed to voice concerns prior to answering them. That's right. Plan to discuss further. You are valuing the patient and respected as equal. Great. Thank you for your comments. So we're going to finish soon with this presentation. I just want to focus on the big picture briefly, and then we'll go into questions. That there are a whole lot of things that influence vaccine uptake, and we're using this model in our work with WHO, which talks about these hesitancy-related things, the what people think and feel, the social processes, but there are also practical issues. And there'll be some people you don't see because they haven't been able to overcome them. So these are some of the strategies that improve vaccination rates in adults. And yes, education does. On-site, convenient vaccination, incentives, free and affordable vaccines, and institutional recommendation makes a difference with healthcare workers. Provider recommendations, as I've said, reminder and recall, message framing, and vaccine champions. And that's a picture of Salisbury Cathedral where they were giving the vaccine in the UK. So a reminder of why we vaccinate. It is about protecting people. It is about reuniting families who have been split by this terrible pandemic. It is about reducing the terrible social costs and the inequities that come from it. And it is about helping businesses come back to functioning like this Pacific Island market. And so the take-home messages are that, yes, we're in a formative time for vaccines. A whole lot of things affect uptake, but good communication and good process will help make a difference to people, and your impact will be felt beyond just your patient in the clinical encounter. Do encourage people to vaccinate after addressing their concerns or helping them find the right information, and minimise the barriers. And as Victor Montori says from the shared decision-making field, be careful and kind. Here's some resources, and we'll make sure that you have access to the slide set so that you can click on these. NCIRS is quite good for frequently asked questions, and they're building on those all the time. And keep calm and carry on vaccinating. Thank you.
Thank you so much. Really, do I get a statue, I think, for that? All right. Thanks, everybody, and thank you for all of your questions. We're going to go through a few of the most popular questions now. So if anybody else has questions, pop them into the Q&A little section at the bottom of your screen there. And if you like someone else's question that's already been typed up there, then you can upvote that and push it up the list a little bit, because I'm sure there's going to be lots and lots of questions and we might not get through all of them. So the question, Julie, that's sitting at the top of the list today is, do you think there'll be increased hesitancy or mistrust following the overdose of 2 patients in Queensland that was reported in the media today?
Yeah, so thanks for that question. So for those of you who don't know, the Minister for Health and the Chief Medical Officer reported an administration error in Queensland that I think occurred yesterday, where 2 patients received the whole contents of the multi-dose vial or near that, rather than just 1/5. This was picked up by a nurse actually and reported. So great patient safety disclosure, and the government have done a good job of disclosing that early and letting people know. Yes, there'll be a few people who are spooked. The anti-vaxxers will jump on it, as they already have, and try and say this whole program's a joke. But fear not. I think in the end, we know that there will be logistical issues. They're going to be reported. There's hyper focus on this. But in the end, people are going to be more confident in a program where the reporting of issues is happening and being addressed, and the public are being engaged, then things are covered up. So yes, the government were faced with one of 2 bad options. One was to report. the other was not, and not to worry people, it's better to report, because then you sustain trust. If you don't and people find out, it looks like you're covering up, and that's very bad for trust.
Agreed, definitely. The next question is around the potential contraindications or additional reasons why people should be vaccinated, should receive the vaccine, around people who are immunosuppressed, pregnant people, people on anticoagulants. There seems to be some conflicting information out there, and this attendee is asking where the best place is to get specific medical information on contraindications and risk factors.
Yeah, great question. Thank you. And I can answer the first two. So the place to go is I think it's called the clinical guidelines, and Suzanne or Karen feel free to just pop in the chat what that is, where to find that, or what they're actually called. But the government have released, based on the ATAGI advice, guidelines for clinicians in the administration of COVID-19 vaccine, and it focuses on Comirnaty, the Pfizer vaccine. And with people who have immunocompromise, it is recommended that they have the vaccine. It's not a live vaccine, so there's no reason to believe that they could get an enhanced disease from the vaccine. And also, they are the main issue with immunocompromised people is that their immune system might not respond as well to the vaccine. So very important they have the 2 doses, and that they're vaccinated, because they're more at risk of serious effects of COVID as well. In pregnancy, the recommendation is this, that if a pregnant woman is at high risk of COVID or getting really sick with COVID, or of COVID transmission. So, for example, in Australia, it would be probably working at the border in quarantine, for example. Then it is recommended, if she can't be deployed, to have the COVID-19 vaccine. But at this stage, the recommendation is that pregnant women don't routinely get recommended to have that vaccine yet, because they haven't had pregnant women in the clinical trials. They are recruiting pregnant women now. There's 4,000 being recruited to a clinical trial to look at the safety of the vaccine. But there's no, in theory, it should be okay for pregnant women to get the vaccine. It's not live. They receive flu and whooping cough vaccine. So it should be okay, but because they haven't had pregnant women in the trials, they're just being ultra cautious. In Australia, they can afford to be, because we don't have a whole stack of COVID. In the US, they're recommending pregnant women have the vaccine. Breastfeeding women can have the vaccine, and women thinking about becoming pregnant can have the vaccine. And there is a nice decision guide on the Australian Government Department of Health website about this whole topic.
Great to hear that that pregnant women are being included in some of the trial data. Do you know how long it will take for that to become available?
It'll take months, because they've got to recruit enough people and then follow them for enough period of time. So we won't be finding out until at least after June, but I don't know for sure. Just going back, the anticoagulants question, I don't have the answer to that, but you should be able to get the answer to that on that clinical advice document. It's quite long and quite useful.
Great, thank you. Should people who've previously tested positive to COVID-19 still receive the vaccine?
Yes, they should. They may get they'll likely get a boosting of their existing antibodies, but there's no problem with them receiving it, and they should receive it.
Okay, there's another question around, I guess, some of the guidelines that came out today, asking, does the guidelines indicate that enrolled nurses can administer the vaccine under the supervision of a registered nurse without a doctor's order?
Yeah, so this is just sort of breaking news today. The government have confirmed with the release of the MBS item descriptor that COVID vaccine can be given in general practice by a general practitioner, a registered nurse, or other suitably qualified health professional under the general supervision of the GP. But the patient doesn't have to see the GP. Every single patient doesn't have to see the GP before the nurse can give them the needle. The nurse can assess their suitability to be vaccinated. Is that an accurate sort of description of the new ruling, Suzanne?
Yeah, I think it is. And I think when we look at the specifics around enrolled nurses, the same rules of scope of practice applies as they do to registered nurses. The same rules around completing the mandatory training applies as it does to registered nurses. ENs in general practice do need to be under the supervision of a registered nurse, but that's standard practice for other procedures, and medication endorsed enrolled nurses give lots and lots and lots of medications and lots of vaccines in their everyday practice now. So it's nice to see that that's been recognised by the guidelines, and extra roadblocks haven't been put in the way of nurses getting the job done and getting millions and millions and millions of people vaccinated.
And a real shout out to APNA and Karen for all the hard work in getting that clarified and advocating for the role of nurses in this, and others who have been involved in it as well.
Yeah, it's been an interesting ride, and it's a great precedent, and we're really happy to see the work of all nurses valued and respected by the health workforce. It's great. We've got another question from Vicky asking if there's any preliminary data on the efficiency of the vaccine in Australia with the Australian cohort. I'm thinking probably not, because we only kind of started at the beginning of this week. Can you shed any light? Is there separate data going to be collected on efficacy within the Australian population?
Yes, I'm sure there will be, and certainly with safety, they're monitoring that very carefully with all the safety monitoring systems we have, like AusVac Safety, where in a select group of practices, patients are texted for them to text in any symptoms of anything they have after a vaccine is given, and other monitoring systems. But in terms of efficacy, like, it'll be effectiveness, because once it's out in the population, you call it effectiveness rather than efficacy, which is a trial thing. So the effectiveness, I am certain, will be evaluated by studies done in Australia, such as by the National Centre for Immunisation Research and Surveillance. But I'm not aware of a specific plan, but I'm sure it will be happening. There is data now from Israel and a little bit of data coming out of the UK as well, showing effectiveness from these vaccines, as we'd expect.
Yeah, we're being in such a fortunate position to be able to watch and see what happens in other countries as they roll out their programs, and use that data and information to make really good decisions about how we do it here. A question around COVID vaccine and flu vaccine. We know that at this time of year, we're heading into the territory where we'll be doing both. So how long do we have to give between the COVID vaccination and flu vaccination? And can the flu vaccination be given between the two COVID doses?
Good question. So 2 weeks between the COVID and flu vaccine. And that would mean if it's 3 weeks apart with the Pfizer vaccine, then possibly not. But look, the thing that I know is that they're recommending a 2 week spacing at the moment. Watch this space, that might change. But at this stage, 2 weeks between COVID vaccine and flu vaccine, which if you have to wait 3 weeks between vaccines, then that's not enough time between the flu vaccine and then the second COVID vaccine. So maybe, get your patients having their flu vaccine as soon as it comes out.
It's going to be a juggle, that's for sure.
Yeah.
So we've got time for one last question. This attendee's been asked a few times already by patients about the human content within the vaccine and what part of human content it is, please.
Okay, I think that might be a question about the fetal cell
cells.
lines.
Yeah.
So this is a question about the AstraZeneca vaccine and probably other vaccines using that platform, where to make the vaccine, they have used cell material that was originally from a fetus from the 1970s, from a termination of pregnancy. And they grow these fetal cells so that they can make the vaccines. So there's no human tissue in there. There are cells that have been reproduced over a long period of time that have helped to make all sorts of medical technologies. And this issue has been looked at from a theological and moral perspective with particular religious organisations. And, for example, the Catholic Church, I think, have made a statement about this. And generally, they don't particularly like the fact that there are cell lines that may come from an elective termination of pregnancy, but they say that the benefits of having the vaccine outweigh those moral concerns.
APNA's next COVID webinar is on the 11th of March and is titled Setting Up Your Vaccination Clinic. Subscribe to the Connect newsletter to receive the registration link. There is a link in the show notes to subscribe.
2021, Year of the Ox? More like Year of the Vaccine. Let's continue to protect the community against COVID-19 together. Members receive priority news alerts from key vaccine experts, access to APNA's COVID webinar series, and a competitive insurance offer to ensure your career is protected. Renew your membership and add professional indemnity insurance today.
Primary care is playing an increasingly important role throughout a patient's cancer journey, from prevention through to palliative care. We are joined by Christy Milley, the National Manager of the Primary Care Collaborative Cancer Clinical Trials Group, PC4. She's also the host of Research Roundup, a podcast for people interested in cancer in primary care. She is here to share some recent highlights from their podcast, which primary healthcare nurses will be really interested in.
Each month, I interview experts from around Australia and the world about their research and the impact it has on practice, care, and what that means for GPs, nurses, and the whole primary care team. Our podcast covers the whole cancer continuum. Speaking to experts such as Dr. Rebecca Bergen, we discover more about the role of primary care in the optimal care pathways and how they can improve the quality of cancer care.
The OCPs have played a valuable role in bringing people together from across Australia to establish what we think is really the best cancer care that all people in Australia should be having.
Associate Professor Julia Brotherton shared her research about the renewed cervical cancer screening program and the preparedness of general practitioners and nurses.
That's the big difference here, to reach the previously unreachable and really hopefully make a big dent in future cervical cancer incidents by doing that is such a great opportunity for all of us.
Dr. Carolina Lissi from the Australian Cancer Survivorship Centre discussed sharing cancer survivorship care between oncology and primary care providers.
So I think we need greater awareness that primary care and shared care is the way to go. And we need people working together to create some sort of national agenda or national standard.
Dr. Annette Berenson and Saskia Maas from the University of Groningen in the Netherlands shared their insights about the long-term symptoms found in breast cancer survivors.
For GP practice, it's good to realize that even 10 years after diagnosis, breast cancer experience various long-term symptoms compared to women who didn't have cancer.
Thanks, Christy. If you'd like to listen to Research Roundup, there are links in the show notes of this episode.
Nursing Australia, the podcast for Australian nurses working together towards a healthier Australia.
Who has the time to wade through every piece of healthcare news? Primary healthcare nurses certainly don't. Fear not. APNA's Weekly Connect e-newsletter condenses key industry news into digestible content while serving up a feast of useful resources. Stay in the know and save time. Subscribe for free at www.apna.asn.au.
For our Nurse Wellness segment in this episode, Dr Avi is back to speak about nurse wellness, resilience, self-care and ultimately self-leadership.
One of the things that I'm going to talk about today is, again, going deeper into the 6E methodology. And in previous podcasts, we covered E1 and E2. Today, we're going to go into E3, which is all about engagement and how you engage and motivate yourself to actually look after yourself in a very, very simple terms. Now, is there really even a problem in motivating yourself to look after yourself? Now, I was just listening to another talk from the Commissioner of Resilience in New South Wales, and he was talking about firefighters and the firefighters during the bushfires and how a lot of them are going through the trauma and this sort of post-traumatic experience of dealing with losing friends, colleagues, and how even families lost property during that time of the bushfires. And of course, all this is now overtaken by the pandemic and how we're now in some ways dealing with the post-traumatic experience of the bad times during the pandemic, which in many areas still continue for nurses and for other health professionals as well. And one of the things that this commissioner was talking about is how some of the firefighters were reluctant to go and ask for help afterwards. Now, this was particularly amongst males, but can happen amongst women as well. And part of this reluctance is the fear of judgment, of having to ask for help, the fear of stigma, of needing help. And particularly for those of us who are nurses, who are health professionals, you know, there is this ego mind, this self-identity that we're supposed to look strong. We are supposed to be the ones delivering care, not the ones asking for care, not the ones asking for help. And actually being vulnerable and actually exposing ourselves to asking for help is perceived to be weak, right? And so one of the things we have to overcome within our own minds to look after our own well-being is actually this sense of ego, this sense of self-identity that we're supposed to be strong, and we're not supposed to break down that wall and show our vulnerability. We have to overcome this reluctance within ourselves to ask for help, to ask for emotional support from friends, from colleagues, and from other health professionals, which we often don't want to do because we might be perceived as weak. And in some cases, I think there is a sense of professional insecurity in doing so as well, particularly in healthcare professions and the care professions. So we really have to overcome that. Now, how do we overcome that? Well, there are two ways in which we can do that, and that is by engaging our intrinsic motivators, that is motivators within ourselves, but also our extrinsic motivators, that is motivators outside of ourselves, to create behavior change within ourselves. So what I'd like you to do is actually just write down very quickly and do this own personal exercise on what these intrinsic and extrinsic motivators might be for yourself. So I'll rattle off a few. So intrinsic motivators could be something like love. Okay, your love, your heart-centeredness to want to be a better person might be self-love, love for family, love for friends. In terms of if you want to lose weight, are you doing it for your kids? Is your love for your kids actually driving that need for you to kind of lose weight? The other one is authority. So sometimes you want to achieve a higher level of authority, and that might be your driver to actually change your behaviors. Achievement, getting an award, you feel that sense of achievement coming through. Sometimes it's connection and camaraderie. Some people like to work in groups and work in colleagues or connect with others in health settings. So the group fitness exercises, or going to sort of fitness levels or fitness groups where you can actually engage with others and connect with others, might be one of your drivers. Recognition, I've touched a little bit about that, but sometimes you want to be recognized as the fittest, the healthiest, the most stable person in the group. That may also drive you. The other one is, another motivator is equity or fairness, where you actually are driven by the sense of wanting to be equitable and to offer a fair and stable environment for everyone in your, either your family or in your work group, might be a motivator. Another motivator is freedom or independence, wanting to be free, wanting to go outside, wanting to do things or be creative in your own way can drive or stimulate your own health motivations. Safety and security is another one. Also, finding your purpose and helping others might be a driver, so you can't help others if you don't help yourself. And the other motivator is avoidance of emotional pain or mental pain is another intrinsic motivator as well. So these are all interesting intrinsic motivators that can drive you. Then there's these extrinsic motivators like money, power, title, sex can be a motivator as well, believe it or not, for you to look after yourself and want to look after your own health, as well as also the avoidance of physical pain in order to do so. So these are some intrinsic, extrinsic motivators. Write them down. Think about what works for you. I'm Dr. Avi. Be well, do good. Bye for now. And I hope this has really helped you in your nursing path moving forward.
Well, that's all we've got time for this episode. Thanks for listening to Nursing Australia. We'll be back in a few weeks with our next episode. I'm Suzanne Blackeby.
Nursing Australia, the podcast for Australian nurses working together towards a healthier Australia. For more information, please visit us at www.apna.asn.au. Thanks for listening to Nursing Australia.